I don't know.
Right?
I didn't
Who else is it?
I did.
Who else would it be?
I don't know.
Amanda ain't smack me like that. That's a hood.
How'd you get it?
Since when, shall we?
Right. A person can change the time with
And then she was like, oh, can I take a break from here? And then she came out to shoot me. They had different names on their group. I'm just giving you
Okay, let's do this.
Let's go.
Let's go. It's been 18 minutes.
Oh my God. We were waiting for you to come back down in the one building. And then you were at the other.
Oh, I'm like a ninja.
We were like, oh, he's not back yet. We don't have to leave.
Generally very calm. Not always. When I'm not in sleep, very nervous. Okay. What? Oh. So are we going to wait for a second?
Please.
over here.
No, because my recording stopped and I had to turn it off. Alright, go ahead. Somebody drop off to me.
To be fair, I am recording. So.
You want to post it on Blackboard?
What?
You want to post it on Blackboard?
Oh, I wasn't planning on it, but
Please.
I just gave it a new thought.
I can. I'm posting it
You
today.
love your video. I really enjoyed it.
I know.
Well, this one's going to be literally, it's right there recording.
Hey, well,
What? There's my other, he didn't get the hints. I like kept hanging up on him like slyly under the table.
and then if he'd have came home with food for just him, he'd have been me.
I would have. I would legit do that. Yeah. Yeah. You should have known. All right. So, boom. I did hit record. Yeah. Okay. Everybody say hi to the day group. Hi, day group. Yeah. Okay. This episode is recorded in front of a live studio audience. Okay, so defects causing a decreased pulmonary blood flow. So we just talked about increase. Now we're going to take it down a notch. Decreased pulmonary blood flow. Our exemplar is tetralogy of Fallot. Accounts for 10% of all congenital heart defects. It has 4 cardiac abnormalities or anomalies. How can you remember that it has 4? What's the hint? That's right. Tetra. So tetra is Greek for 4, right? So we have 4 different things going on. One is pulmonary infundibular stenosis. Ugh. Okay, so let's break this down. Pulmonary. Lungs. Good, we're good there. Infundibular. Anybody? What's that? So that's the stenosis part. Stenosis means that it can't go out. Infundibular is just outflow. Just a word for outflow. So, huh?
Why don't they say outflow?
Why don't they? I don't know. Because this is more infundibular to say. Oh. Yeah. I just came up with that right now. So I know. Okay, so pulmonary infundibular stenosis, pulmonary outflow, narrowing, or occlusion. Right? Cool. Large VSD, we know what that is. Right? We're good with that now. Okay, here's another fun one. Dextroposition of the aorta. Dextroposition. Anybody know what dextro means in Greek? Like ambidextrous, sort of. It actually means to the right. So to the right with the aorta. The right with the aorta. The other term you might hear is an overriding aorta, which will make a lot more sense when we look at the picture. Okay? And then right ventricular hypertrophy. That's right, hypertrophy. Okay, so those are the 4 things that make up the tetralogy of Fallot. And let's kind of see what they look like. Okay, so here's our normal heart. You're all ready for it? Okay. So, number 1. What is number 1? That's our VSD, right? That's our ventricular septal defect. Okay. Does anybody notice anything weird about the coloration here? It's magically shunting the other way, right? Oh, weird. Okay. So something's a little off, right? So you can tell something's a little off. Well, what's number 2? This is the pulmonary infundibular stenosis, right? So this is pulmonary outflow. Something wrong. Okay, stenosis. Something is narrowed, or the valves are kind of closed. Something is going on, right? Okay, cool. So if this is closed off or narrowed, how is that going to change pressures? All of a sudden, right ventricle has higher pressure than left. So when we pump, which way is the blood shunting? Yeah, so now the blood is shunting the other direction, from right to left, because that pressure changed. Okay? Does that kind of make sense? Good. Okay, so here is our aorta. Now, aorta usually sits over here, right? But it's shifted to the right. We know that dexter position. And we also call it an overriding aorta, because you can see it sits right over the VSD. So it rides over the VSD. Okay? What does that mean about the blood that's going to go to the body? It's going to be mixed. They're never going to get fully oxygenated blood. It's always going to be a little deoxygenated. Okay? And number 4 is, that right ventricular hypertrophy. It's nice, thick muscle. Again, sounds great, but no, not so much. Okay. So why does this decrease flow to the lungs? Why do we classify this as a condition that decreases pulmonary blood flow? Right, yeah, because there's less blood that can go through this pulmonary artery because of the stenosis, right? So our lungs are not getting as much blood. So it's a decrease of blood flow to the lungs. Okay. So, in theory, if we wanted to increase flow into the pulmonary artery here, what could we do? We could dilate it, yeah. What natural occurring anatomical structure might help here?
PDA.
A PDA. So this is one of those things where a PDA might actually help, right? Because if we allowed a little blood to flow here, the pressure is cut off here. So there's not a whole lot of pressure in the pulmonary artery because of that stenosis. So the blood pumped from the left ventricle would actually still go into the pulmonary and increase blood flow to the lungs. So PDA is actually pretty helpful there to increase flow to the lungs. So some of our signs and symptoms. What do you think you are going to see with tetralogy of Fallot? So in what situation are they going to squat? In their tet spells, a hypoxemic tet spell. They will squat down. Okay, and we're going to talk about those in a minute. What else are you going to see? Cyanosis. Yeah, that's number 1, right? Cyanosis. If when that right ventricle gets really big in little babies, what do you think you see on their chest? You can see what's called a sternal lift. So you can actually see their little heart pushing their sternum up. It's pretty crazy, right? We're also going to have a lower base O2 saturation. That makes sense, right? Clubbing, even in our toddlers, because they're going to be always a little O2 deprived. Our last one is the heart murmur. Yep. Heart murmur. And what causes the murmur? The VSD and the constrained infundibular stenosis. Yeah. Good. So we've got the squatting that we talked about, exertional dyspnea, tachypnea, feeding intolerance, polycythemia. What's going on there? What is polycythemia? Increased red blood cell production, right? Polycythemia. So why? Why? Yeah, because the body keeps thinking, oh, we don't have enough oxygen, right? And that's because these kids always have mixed blood, but the body doesn't know that, what's going on in the heart. So it just says, oh, I must not have enough carrying capacity. Let me make a bunch of extra red blood cells and I'll help this. That's actually not helpful, right? So we have to watch out for the polycythemia. All right. So this is what's called a TET spell. And TET spells are pretty vicious cycles. You'll see the blueness around the lips, on the extremities. These are the blue babies, if you've ever heard that term. Tetralogy of flow kids, those are the blue babies. And the problem is that they can be brought on by almost anything, but commonly it's brought on because like kids are really hungry, so they work themselves up. They work themselves up, and then they get really upset, and then they go into a TET spell because they're hungry, right? What can't you do when they're in the middle of a TET spell? You can't feed them. Yeah, so it's really, really tricky. So we're trying to prevent them from going into a TET spell. And anything can really send them. Anything can. But feeds are a common reason. Or being hungry, I should say, is a common reason for them to go into a TET spell. We can diagnose tetralogy of flow with a chest x-ray or, of course, an echo. An echo can detect this in utero as well. Okay. Our nursing diagnoses, impaired gas exchange, imbalanced nutrition, and anxiety. Right? For planning, we want the parents to be able to verbally identify 3 signs and symptoms of a TET spell. So what are those going to be? Blue, yep, blue lips or blue extremities, good. Tachypnea, yep. Is that squatting? Yep, position. Good. So those are 3 signs that a parent can see pretty easily, right? Good. 2 interventions to employ during a TET spell. So what do you think we need to do during a TET spell? Okay, so we can increase pressure, right? We can increase the pressure within the basically body column. How would we do that? In chest, by increasing systemic vascular resistance. Okay, that's the fancy term, right? Heated chest increases systemic vascular resistance and keeps the blood shunted towards the middle of the body where it needs heat. What else can we do? How can we reduce oxygen demands? Try to keep them calm and quiet. Sure, yeah. You sure can? Yeah. We can give oxygen if we need to. Sure. Good. Parents may or may not have that at home, so that's something you might want to ask them about. They might go home with a little bit of supplemental oxygen for those days. And of course, we want them to exhibit increased activity tolerance. Right? Okay. So what is our nursing care? Provide oxygen as prescribed. Help child assume that knee-to-chest position during hypoxic episodes. So that's what's happening here, right? You take those little baby legs and squash them up, and then their knees come up to your chest, or to their chest. She's kind of like midway through, I think. Those knees should really be higher, but this is what the kids do themselves. Okay, so that's typical squatting behavior for a TET baby. Be a calming presence in the room. That's really important. Because what is baby's first instinct? Freak out, right? It doesn't know what's going on. It's a baby. It just knows that it doesn't have oxygen. What are parents' first instinct? Freak out. What is nurse's first instinct? Freak out. Yeah, but you're the one who has to be the bigger person because it's not your baby. So you got to be that calming presence and just try to make them believe that things are going to be okay, and then it will be. If they believe it, you make it happen, right? So pick the baby up, put the oxygen on, try to calm the baby, leave the chest, all that good stuff. Yeah.
But this is not a situation where we would use that 20 seconds to allow them to compensate for themselves.
For apneic breathing and things like that, you mean? No. We want them to be breathing hopefully normally. But they might be all worked up into a tizzy, so they might be like screaming. Yeah. Which is awkward because the screaming use more or less oxygen. So use more oxygen, make it worse. Yeah. So if they go apneic during a TET spell, then that's probably a bad thing. So what are we going to do? We're going to use a little bit of morphine. Very, very low dose morphine will actually relax the heart muscle. That's why we use that. Very small dose. Propranolol, sodium bicarb maybe. I don't want you to worry about these medications so much as the other cardiac meds, because these are really specific just to this. So don't spend a lot of time here, okay? Yeah. So palliative treatment for tetralogy of Fallot. We're going to start off with what's called a BT shunt. BT stands for Blaylock-Taussig. Anybody work at Hopkins? Yeah, sound familiar a little bit? Yeah. So those are, I think, two of the buildings, or one of the buildings at least, the Blaylock building. So where do you think the BT shunt was invented? Hopkins. Yeah. And basically what it does is it connects the aorta to the pulmonary artery. It's a little tube that connects those two. Have you seen that before? A little tube that connects the aorta to the pulmonary artery? A PDA. Mm-hmm. So they essentially ripped off nature and just came up with a PDA. They're so smart. So smart. Yeah. What is that? T-board? Taussig. Taussig. T-A-U-S-S-I-G, I think. Yeah. And there's a movie, Something the Lord Made, I think is what it's called, that is about this. And it's either about, like, a white doctor ripping off a black guy or a woman. I forget which one, but somebody's ripped off, I think, and that's Blaylock.
His surgical assistant is a black guy who cannot be accepted into the medical program because he's black.
There you go. Yep. And so that gentleman was pretty much written out of history, and he gets no credit while the other guy gets all the credit, as is the way of our world, unfortunately. So I've heard it's actually a really good movie, and shines light upon that which was in darkness before, so pretty cool. So BT shunts, performed in infants of small gestational age, and it just allows for blood flow. Yay! So then we get more into the lungs, right? Cool. Corrective surgery is big. That's a big one, right? So what do we do for corrective? What do we need to fix? So we have to go in and close the VSD. Okay, so that's all closed up. Good. What else do we need to do? The stenosis, the pulmonary stenosis, right? So they got to go in there and either replace the valve or widen it up. They need to do something to make that bigger. Yep. What else do we need to do? We have to move the aorta over, right? So we move it over to the left so that it sits over the left ventricle as it should. And then what's the last part? A hypertrophy. How does that resolve? How do we take care of that? It's going to naturally resolve, right? Because the pressures are going to be correct now. Pressure is going to be in the left where it should be. And so the right is not going to have to work as hard, and the hypertrophy will eventually resolve. All right, make sense? Crazy invasive. Kids on bypass for the duration of the surgery. So definitely not without risk for patients. It's super cool, right? Super cool. Questions about tetralogy of Fallot? Awesome. Okay. Defects causing obstruction to systemic blood flow. Systemic blood flow. You do?
So, what is it that causes, like just a regular, like a PDA or whatever, versus technology?
So that's going to come down to genetics, risk factors, things like that. I don't think that they know exactly why some of these defects happen. This is not uncommon either to have like a BSD with a PDA together, things like that happen. So I'm not sure what physiologically happens so that a child develops one and not the other. It could have to do with genetics or risk factors or things like that.
Is it like are they like babies usually, or?
A lot of times they are smaller, but they can be carried to term. If it's congenital, then it could just be like a genetic thing that happens. Yeah. So a lot of the babies are otherwise healthy and don't have any other comorbidities, except for the cardiac issues. So, I want to say, like, was it Jimmy Fallon? Jimmy Kimmel. Yeah. Jimmy Kimmel. So he's been talking about it, which is kind of cool to like have it publicized like that and have that struggle and how crazy it is. But you have to assume that, you know, his wife probably had extraordinary prenatal care and was well taken care of during the entire pregnancy, but still. So there's got to be some genetic component like that. Cool. Any other questions? Great question. All right. Defects causing obstruction to blood flow. Systemic blood flows particularly. We're going to talk about aortic stenosis. Obstruction due to the narrowing of the aortic valve. Valve is often malformed. 10% of CHD. And another fun one, coarctation of the aorta. This is a narrowing of the descending aorta that impedes systemic blood flow. 8 to 10% of CHD, so not very common. So let's talk aortic stenosis. Are you predicting what we're going to see here? What are we going to see? Whoop. There it is. So blockage right here or at the valve level. So it could be either place. It could be in the actual aorta or at the valvular level. Right? I don't know why this is not aortic infundibular stenosis, because it's the same thing. Why we couldn't just call it a pulmonary stenosis, or why it can't be consistent, but it's not. Aortic stenosis will result in decreased blood flow to the body's system, right? And why? Yeah, the aorta is blocked, so the blood just can't physically go through. So let's think this through. Blood can't go through, so what's going to happen in the left ventricle? Increased pressure. So then what's going to happen? Hypertrophy. That's right, left ventricular hypertrophy. And then what's going to happen? You're going to get back up into the lungs. Yep. Perfect. Pulmonary edema, myocardial ischemia. Lots of unfortunate fun things. Okay, coarctation of the aorta is kind of the same idea, but a little different, right? And that's because the narrowing is in a different place. Right? So where's the narrowing here? Descending aorta, distal to the SA. What is SA? Subclavian artery. Subclavian artery. Okay. So why is that happening? Why does this happen? So it's idiopathic. We have a backup of blood flow here, right? It's going to go back. So all those things that we talked about are going to happen again. But how is this different than just regular aortic stenosis?
Well, one of the things is going to be the pulses. The pressure is going to be different depending on where you're checking.
Okay, so she's saying that pulses or pressures are going to be different depending on where you check on the body. Well, why is that? That sounds crazy. Are you crazy talk?
No.
Crazy talk. Why is that?
Because for the subclavian arteries, everything that's being fed off the subclavian arteries are going to be higher pressure. Everything off the abdominal aorta and descending is going to be lower pressure.
Perfect. So this coarctation takes place after the subclavian artery, which is basically the last artery to perfuse the upper half of your body. Okay, so blood pumps here. Whoop, it gets to this part, and then there's a narrowing. Oh, crap. Right? So then it's going to be forced forcefully through all of the arteries that perfuse the upper body. And what about the arteries that perfuse the lower body? They're going to have this little trickle that comes past this coarctation. So upper extremities are going to be, what is the pressure going to be like there? Bounding. So they're going to be hypertense in the upper extremities, and the lower extremities are going to be hypotense. Mm-hmm. Yep, so there's a big difference in pressures. Pretty crazy.
So does that mean that in the upper extremities you'll get like nice and pink, but the lower extremities you're going to be probably a little cyanotic?
Yeah, so you might be nice, warm, well-perfused pink in the upper extremities, and then lower extremities probably a little bit cooler, not well-perfused, maybe a little cyanotic. Yeah. If you're an adult, you won't have hair growing on your toes, right? Did they teach you that here?
Yeah.
That's what they taught me, and that always stuck with me as being both gross and a good way to remember it. So, cool. So does this make sense as to, this one is almost a partial decrease in blood flow to the system, right? Because the upper half of your body actually gets a lot more blood flow. The decrease is to your lower extremities. What are you at risk for here? No, not quite. It's not infection. Yeah. So we're talking about aortic rupture, which is generally frowned upon. Not a great thing, right? So all that increased pressure, we gotta worry. Okay, so again, we are looking at this both column, signs and symptoms of heart failure. What kind of signs and symptoms are you gonna get? Right-sided, maybe left, maybe a little bit of both, right? Okay. Murmur, delayed cap refill, especially in those lower extremities, and decreased urinary output for both of them. The kidneys are not going to be perfused as well. Okay. Diagnoses: decreased cardiac output, ineffective tissue perfusion, and risk for injury. What's the risk for injury in kids particularly? What do kids love to do? They love to run, and if their legs are hypotense, they're going to go down, right? So that's their risk for injury. We're hoping that we're going to show improvement in cardiac output, parents able to identify signs, and participate in appropriate activities, right? So what are some signs of worsening condition, particularly for this one? Anyone want to take a guess? We have edema, generalized edema, tachycardia, still, chest pain, and syncope.
Is it syncope?
Syncope, yeah.
Generalized edema, syncope, chest pain, and what was the other one?
Can you tell me?
Tachycardia, perhaps?
Bing.
Thank you.
Good work. All right. Nursing care. We're going to teach parents sign of condition, facilitate parental expression of feelings, encourage support physically and emotionally, pharmacological care. Prostaglandins. What's that all about? Keep the PDA open. Now, one thing to know about prostaglandins, and this actually can raise some really interesting ethical questions. Prostaglandins are usually only used if they are considered a bridge to surgery. Okay, because prostaglandins are a 24-hour drug. You have to be in an ICU to receive prostaglandins, either NICU or PICU, and it's not natural, right? Mm-hmm. You're faking the little baby's body out, thinking that it's still attached to a placenta. Mm-hmm. So, ethically, you're really supposed to only do it if we're a bridge to surgery. But there's kids who have been on prostaglandins for like months and months and months, and then you have to wonder, like, when the kid can't live on prostaglandins. So what are we doing here? And why are we doing this? You know, diuretics and inotropes. What are inotropes? What do they do? Contractility. Yeah. So they increase or change the force of contraction. Right. Those are like inotropes. What are the other kinds? What's the other big one? A chronotrope. What is a chronotrope? Yeah, so those are drugs that change the rate, right? And again, you have to think of Greece, or Greek words. Chronos is the god of time. So, chronotropic drugs change the timing of the heart. Inotropes change the force of contractility. Yep.
So prostaglandins are used to keep prenatal labor. Why can't prostaglandins do a PT?
In theory, they could. Yep.
Maybe
They
they
could.
can strong enough for surgery.
They might not be strong enough for surgery. Yeah. Yep. But yeah, no, in theory, they could do a PT shunt as well.
But they have to be ICU
To get prostaglandins, you must be a nurse. There could be exceptions to that, but I would be very surprised. And that's only because prostaglandins have a very short half-life, so as soon as they're turned off, the body's like, okay, we're done. So if that's actually sustaining, if the prostaglandins are sustaining life, then it's incredibly dangerous to have a nurse who has like 4 patients and move them on prostaglandins. So you're in an ICU, so that nurse can make sure that everything's fine. Okay, so how are we going to fix some of these? So coarctation, or some sort of narrowing, we can do a balloon dilatation. And they just go in there and pop it open. That's with the cardiac cap. And they can't do that if there's a valvular issue. They can't pop the valve open. But they can if it's outside of the valve. So the valvular problem, they have to deal with the valve itself, right? They can also surgically resection, where they just cut out the narrowed part. And so back together. Okay. That's an intervention for either of those 2 conditions, but again, if it's a valvular problem, then the valve has to be addressed, and these things don't fall. But, make sense? Cool. Okay. Questions here? All right. So next is our defect causing mixed blood flow. And our exemplar is transposition of the great arteries. Very cool. So the aorta is connected to the ventricle, right ventricle, and the pulmonary artery is connected to the left ventricle. Okay? So let's think this out. I'm going to do a little drawing here. So here's our little ventricles. Okay, so this is the right, this is the left. Right? Okay, so let's read up there. The aorta is connected to the right ventricle. So here's right ventricle, aorta. Where is this going to go? Goes out to the body. All right, cool. Here's body. And then where does it come back to? From the body, it goes back to the vena cava and back to the right atrium, which then goes to the right ventricle, which then goes to the body, which then goes to the right atrium, the right ventricle. Okay, so we kind of see what's going on here, right? And then over here, it says that the pulmonary artery is connected to the left ventricle. So here's the left ventricle, and this is the pulmonary artery. Where are we going? The lungs. So here's my little lungs again. I'll move out of the way so y'all can see in a minute. And then lungs are going to come back to left atrium. Okay. So what do we got going on here? Here's our body. Well, that's awkward. But the lungs are like super well. Look at this. Ooh, red, red, red. So what's the problem here? Yeah, body is never going to get oxygenated blood in the system, right? Transposition of the great arteries. They got mixed up. This is what happens when they get mixed up. You have 2 separate circulatory systems within one body. Is this compatible with life?
No.
Generally, no. No. Not so much, right? So that's why we get to line 2. A septal defect or a PDA must exist in order for the patient to receive any oxygenated blood. Okay, so how can we get this kid some oxygenated blood? Yeah, we open up and we make a little tunnel between the two ventricles. Cool. Fortunately, we should still have some pressure going on here, which is going to bring our blood over to this side. And now, what are we getting? What is our little man getting? Slightly oxygenated blood. It's something. Something is better than nothing, right? It's the same premise with the PDA. The PDA allows a little bit of blood. Okay? So here's what that mess looks like. Pretty crazy. Okay. Make sense? Yeah.
So, when they're first ordered like this, like they don't have long to like figure out that this is what's going on
Right.
and like fix
Correct. Yep. Correct. Yes. We do not have long to figure out what's going on and fix it. However, what usually stays open? And why? The PDA will usually stay open because it needs there's two different things it needs to close. One is a decrease in prostaglandins, the other is the increase in oxygen. What is it not getting? The oxygen. So usually this PDA stays open because those two conditions are not satisfied. They are not met. So these kiddos are born and they've got a fighting chance. Not a great chance, like if it's not addressed right away, or near right away, but they are born with a fighting chance. Yeah.
I just had a question because my niece actually had tuberculosis 4 years post transplant, and I couldn't remember her condition. And then when I was listening to her, I had to confirm my sister, but she had a left type transposition of the great artery, ASD, VSD, and Epstein's anomaly, and right hypoplastic right ventricle.
Yeah. So
what would that
a lot
look like?
A lot going on. Okay. So basically like this,
Uh-huh.
what is the hypoplastic right ventricle? It's when it's tiny. Right. So this ventricle would be like that big. It would be like that.
Okay.
So like nothing. And then she had an ASD and a VSD. ASD and VSD, which was actually good, right? Which turned out to be good.
Mm-hmm.
So that means that there was no wall up here, and there was no wall here.
Okay.
So this tiny little nubbin of a right ventricle was completely connected to the left ventricle, and then there was nothing separating the two people,
Okay.
which in effect saved her life, right? Because even though the plumbing was all off, there was still blood going to the lungs, still blood going to the body, never purely oxygenated blood. So she was probably one of those little ones who were satting in like the 75, 85 range, and they kind of had to be okay with that because that's probably as good as she could get, right?
Mm-hmm.
Yeah. And she's post-transplant?
Yes, she is. She just turned 9. I think this is 3 or 4 years post-transplant. And
Doing good?
she couldn't even start her bottle, and now she's a cheerleader. She's a flyer.
Oh my
She
God,
cheerleads
that's awesome.
everywhere.
Oh, that makes me so happy. Gives me all these
Yeah.
little goosebumps. Oh, good. Yeah, it's amazing what medicine can do these days, and nursing, right? Cool. So obviously, what we're going to see is a lot of cyanosis, progressing to hypoxemia and acidosis. This condition is not going to improve with oxygen, right? You can slap oxygen on these babies; it's not going to do anything. They just literally don't have the connections in place, and that's the problem. Okay, feeding intolerance, growth failure, dyspnea, obviously. Impaired gas exchange, sure. Decreased cardiac output, fear and anxiety, that's for the parents, of course. I mean, if an infant is capable of having those feelings, I'm sure they are feeling them. Parents are definitely feeling them, right? Child is going to be well perfused with acceptable cardiac output, nutritional needs met, knowledge of diagnosis. So we are going to, what are we going to do? What is this child going to have? They're going to have surgery, right? It's not a maybe we will. It's if we intend to save this child's life, they need to have surgery. Okay, so we're going to keep them as calm as possible, provide nutrition, fortified nutrition, and let them know what post-op is going to be like. There is going to be a problem. So pharmacology, there's our prostaglandins again. We are making sure none of those conditions are met. We want that PDA to stay open, so we're going to give the prostaglandins. Antibiotics, again, prophylactic for surgery. We know it's going to happen. And diuretics, we don't want that kid fluid positive. Right? So we want the nutrition without the fluid. Right? Quick treatment is going to be the atrial balloon septostomy. That's going to create an ASD or a VSD. So they go in with that cardiac cath and they blow it open. So we're not fixing anymore, we are tearing it down. So that's if we just have that little PDA, we're going in and we are creating this tunnel between the two ventricles. Right? And pretty amazing, they can do that with the cardiac cath. Right? This little baby's life can be saved through this tube going up through their femoral artery into their heart, popping it open. So neat. Corrective surgery, they literally take the arteries and switch them back. And then they're all good. It's getting to that point, right? So these kids must have surgical intervention in order to survive.
I have a question. Why
Yeah.
do they risk some kind of gas exchange instead of just some kind of gas exchange?
Oh, because it's nursing, we're silly.
Okay.
Yep.
I was just wondering. I was like, I'm pretty sure they don't. Okay.
I think we're beyond risk. Yeah.
Yeah, it's good.
Yeah. Good question. Wish I had a better answer than that. But. Okay. Moving right along to bacterial endocarditis. We got through all of our structural exemplars. Feeling okay about those?
Yeah.
They all work? Yeah? They're all pretty cool. Okay. Bacterial endocarditis is an infection of the inner lining of the heart involving the valves, mostly caused by Streptococcus aureus, brillians, whatever. That's there. If you want to study them, you can. The only thing important to know is that these bacteria are native to the body. They're part of our native flora, so they're already there. They're just waiting for the right opportunity. Uncommon in children with healthy hearts, and will typically result in days to weeks of treatment. Okay? So the kids who are at risk are cardiac kids. Cardiac kids are at risk for bacterial endocarditis. So we need to think about when we're going to treat them with prophylactic antibiotics. So when do you think we would want to do that? Anytime they're going to have surgery, they're getting prophylactic antibiotics because of bacterial endocarditis. This is what we're going at. What else? Dental work. Yes. So those bacteria that we just talked about are really common in the mouth. So if we have bleeding and we have the chance for those, nope. Prophylactic antibiotics, dental work. There you go. What else? Other common infections, maybe? What do you think?
Like if they get sick of something else, and their immune system isn't good.
If we have a depressed immune system because of a comorbidity, we'd probably give a prophylactic antibiotic. Yeah. They go into the hospital, yeah?
I was just told today that, like strep throat can cause endocarditis. So you've got a sibling with strep throat? Boom.
Yep. So, yeah.
I was going to say, what about like extensive lacerations that you haven't started doing?
Oh, extensive lacerations, you mind. Yeah. We're really careful with these kiddos. It's not necessarily staff, but they're pretty careful. Even when like a Foley goes in, if we put in a Foley, prophylactic antibiotics, right? Because that's central lines, prophylactic antibiotics. Yep, for sure. Okay. So it's one of those weird things. There's no one thing that diagnoses endocarditis. It's gradual onset of symptoms, recurrent low-grade fevers. They never get too high, never too crazy. Fatigue, weakness, joint and muscle pain, new onset of murmur because this is a valvular problem. right? And Osler nose. Remember what those are? Yeah, those are the ones on your finger, toes, feet. Weird, right? Finger pads. And red, like red painful bumps. Nudes. So the Duke criteria is how we diagnose it. And really, it's a positive blood culture with one of those organisms we talked about, likely. An echo and presence of clinical symptoms. So if it looks like a duck, talks like a duck, it's probably a duck, right? That's what this means. So they're going to diagnose it if those things are present. Nursing care, early detection and treatment. Pharmacology, clindamycin. Why is clindamycin such a nice antibiotic? Broad spectrum, that's pretty much everything, including the major organisms that cause endocarditis. Okay. Prophylactic antibiotics, of course. Our complications: heart failure, spread of infection, stroke, organ damage. Okay. Boop. Nope. No. That's all I got for you. Questions? Yeah.
The question is, you may have said it, but I mean, with the prophylactic antibiotics, are you using just raw antibiotics as a prophylactic, or?
Yeah, I mean, I put clindamycin on there because that's a good antibiotic to know. You'll see it a lot now in clinicals. So I included that one just as an example of it.
Okay, but it would be, if you're giving somebody prophylactic antibiotics for dental surgery or something, you would be giving them those prophylactic.
Yep. Any other questions, thoughts, concerns? Yeah?
Just a question about the finals.
Uh-huh.
How much of it
Oh, so we're kind of, do you hear the hush go over the crowd? Yeah. So we have to include a cumulative component on our finals, right? But pediatrics is kind of sneaky about that. Like, yeah, there's probably going to be like a blood gas question, they'll probably do that, but we like to incorporate it, right? Like you have one of your nutrition exemplars was something about like vomiting or pooping or something, right? So it'll probably be like, what's the blood gas of this kid who's been vomiting or pooping or whatever, right? So we combine it. What's the other big thing that we like to combine and throw in everywhere on the exam? Growth and development. Yeah, growth and development is everywhere. So that's another big part of our cumulative component, is how you treat these children developmentally appropriately. So there's no like number per se, but the bulk of it is going to be on new content, for sure. Good. All right, I will see you all on.